With this interview, we are celebrating the MDS Congress in Madrid that took place a few weeks back. And first of all, thank you very much, Professor Bhatia, for accepting this invitation for moving along. Congratulations for your award. You have been given an Stanley Fahn Award for your work. We, as your fellows, we are so proud of you, but what does this award mean to you personally?
Well, obviously it's a big honor and privilege to be, bestowed with the Stanley Fahn Oration Award. And I'm thankful to the MDS to consider me worthwhile for this. So, Stan was somebody we were all idolizing and idolize along with David Marsden. So to do an award in his name is indeed a big honor for me. So I think you were mentioning about, just before we started, about the question about the content of my talk, and you are given an open slate, and they don't give you a topic, so they tell you to choose your own idea about what you want to say. And I thought that as I've seen recently with these major advances in the genetics, in the autoimmune and disorders, particularly with the genetics, that the clinicians are finding it a bit difficult in their own mind, I think, given that quite often the diagnosis seems to have been made only on whole exome sequencing or something like that. And the clinicians sort of feel a bit demoralized, perhaps, and the question starts being asked is there a role for the clinician? And I thought, therefore, having been a clinician myself all my life and a clinical academic, I thought that would be the topic I would try and address. So that's what I chose to speak about.
So can we also say that you, as a fellow of Professor Marsden and Stanley Fahn, you were kind of infected with the idea of structuring the neurology examination with phenomenology first? Is that those mentors influenced you in that way?
Indeed. I mean, I never worked with Stan Fahn directly. I was David Marsden's fellow for a long time, but I had interactions with Professor Fahn because of the close, relationship he had with David Marsden. So, and I saw him at the American Academy. They used to have these unusual movement disorder sessions, which we used to all attend, which used to go on for hours. And they really dealt with phenomenology at that time, and that's what we used to learn. So yes, you're right. Phenomenology is a sort of, I still believe, is a crucial plank upon which all the diagnoses and etiologies have to be considered. So there's no escaping that even now. So yes.
Yeah, exactly. I think that maybe it's even more important right now, having all those advances in the new diagnostic tools. We still need to kind of reflect on the phenomenology, because otherwise we are totally lost with the number of genomes that we can get from the results. Right? So what is your know-how if you would recommend something for a young movement disorder specialist? How to start to be successful in structuring the neurological examination and starting with the phenomenology?
Well, I think one has to learn from others who are in the field, obviously, and one has to sort of be observant pick up the signs. Those are very important. So phenomenology is a lot about spending time with your patient, observing them, picking up this. But then there is the second aspect, is what I think is the putting together things in sort of little, in my mind, you slot things into various boxes, and then you sort of build a syndrome, and after that only you think about the etiologies which may be relevant for that particular syndrome. So you can only make the syndrome if you pick up all the signs, and you're able to fill that slot with those particular symptoms and signs. So that's very important, and that I think that is something which we, as part of the MDS, have to teach our new fellows. And then new people who come into the field. That's extremely important.
So how would you recommend to run the genetics? Is the project that you mentioned, like the one with 100,000 genomes, is it a feasible way to make a kind of a screening for genetics, or you have your own approach?
No, in fact, what I said was that the 100,000 genome only gave an answer in about 18%. So in fact, the large proportion of people, such a big genetic project, so far at least, hasn't produced a definitive answer. What I was saying, in fact, was that what I was saying is that people in the beginning, when we started in the movement disorder field, we were all made to learn how to develop the phenomenology of these various hyperkinetic movement disorders. It's a completely new thing. So those who came into movement disorders had to up their game. They had to learn this, okay? It wasn't there before. And this is a relatively new thing which was present. And we have become successful at that. We can now do that. And what I'm saying in my talk, as I said, you don't need to know each and every gene. So there are 45 scars, or maybe more, or 25 dystonia, then 30 Parkinson. You don't need to know each and every one of them. But there is a certain, I would say, there is a certain expectation, which I think if you want to up your game, just like you did at the beginning, that there are certain, the common ones which are now so clearly visible as you need to know those, I think. So for example, I gave the example of benign heterochorea, and the core phenotype of those 2 or 3 different genes is now well described. And you need to recognize core phenotypes. And although there are many different genes, certain core phenotypes remain true. So if you're thinking about somebody with Huntington's, you will still think in somebody who's got chorea and cognitive problems and so on, and eye movement disorder, the core phenotype remains true. And you would consider Huntington as the most frequent and so on. So in that way, for many of the movement disorder conditions, may it be dystonia, may it be chorea, may it be Parkinson's, core phenotypes are now recognized and should be recognized by clinicians who are working in the field. You cannot be pardoned, in my view, if you don't pick up the core phenotype of an MDA, okay? 20 years ago, you didn't need to know that. We didn't know that. But now you need to know that, okay? Exactly. You cannot miss an MDA phenotype. You cannot miss a facial-brachial dystonic seizure phenotype. These are now become what I would say part of our, should be part of our basic learning. just like in the beginning, we started learning about how to differentiate chorea from tics and myoclonus and so on. That was step one. Now we have to be upping up a little bit to this step, that we are able to recognize, if you're going to work in the field and you're going to call yourself a movement disorder expert, it becomes important for you now to know these core module phenotypes, and I think this module has to be part of our education now. So we have to be able to teach our residents, our fellows, even other movement disorder grown-ups, if you want to use that word, that they now need to know these. There is no escape. It's important.
Yeah, exactly. You also mentioned about the ethnicity, right? That sometimes it gives a hint.
Yeah.
Can you?
Yeah, absolutely. I mean, again, I mentioned that because, now there is so much movement across the world, people are moving from one side to another side and so on. And you do need to be what I call a international neurologist, So you need to know, again, in your basic workup, that certain ethnicities have certain types of syndromes, As I mentioned there, the HDL2, which is seen in Afro-Caribbeans, can present with chorea or can present with Parkinson's. This is something we have to recognize and have to know, certain types of scars are more common in certain populations. Ashkenazi, Jewish, etc., have certain genes more common in them. So this is, again, part of your basic training. This is now become, or should become, part of your, even your average movement disorder person will now need to know these things because, as I said, we have to step up. So we can't sort of bury our head in the sand and say, okay, I'm going to carry on just the way, because there are treatment implications. Okay.
Yeah,
if you don't pick up the NMDA and you don't pick up the LGI1, there are treatment implications. There are management implications. They may not be curable, but there may be management issues. So I think even more so now, people need to know phenomenology, and even more so, people need to learn how to recognize the classic syndromes. Okay. Mm-hmm. Previously, we knew a few things we shouldn't miss. So we'd say, okay, don't miss Wilson's, don't miss DRD. But now there are 30 treatable rare conditions which you can't miss. Exactly. So it is necessary to, as I said, to up our game and learn phenomenology, learn the classic syndromes, learn particularly the treatable disorders or where there are management issues.
Exactly. And I think that it has also implication for the precise medicine,
yes,
the
precision medicine
part, of your talk.
Yeah.
So can you tell us more about that? Is it already here?
Yes, I mean, again, as I was saying, there are management issues, and I gave a few examples. So no more is it, so for example, if you see somebody with, ataxia with oculomotor, apraxia, etc., you're thinking about ataxia or its variants. And this is a, DNA fragility disorder. They are at risk of cancer. So firstly, you need to identify the condition. You should have got it right from the phenotype. You should have asked for the right genetic test. And then you are looking at the SIBs and the relatives and so on who may be afflicted and may be afflicted by, a genetic condition. So this is, a cancer, for example. So this becomes important as part of your management. If you don't pick up the classic Niemann-Pick type C, ask for the test, you can give them miglustat. It is treatable partially. And there are some which are like AADC. Recently, there has been this paper, where the vector treatment with the replacement of AADC into the brain has been almost curative. So precision medicine is already here. and we have to keep up with that. It's very important that, and I'm sure that in the very near future, it's going to be also, I suspect it's going to be as medico-legally binding as it would be for, say, for example, if you miss Wilson's, okay? So these are things we have to keep pace with. And, we have to, as I kept saying, we have to improve our game, bring it up. And we have done that before. It's a question of just becoming aware. I think the problem also is that people are not completely aware of this, that this is achievable. It is not out of, that you can't achieve this. What I feel now is, we learn the basics and we are one step ahead, and this step is also achievable. It's possible that in the future, you will have your AI platforms and you will have your this, and you put in your search terms, and but at the moment, at least, even if you go into Google, who puts things into Google related to a particular syndrome? It has to be the clinician, right? So till these data sets are developed, and these data sets are going to be developed by clinicians. So for the moment, at least, you're very much required, to learn phenomenology, to learn these basic things, if you want to call yourself a movement disorder expert.
Okay, so the last question would be, so what is the future plan for Professor Bhatia? What are you going to, to do now?
I think that Professor Bhatia will plod on like he has been doing all these years. I enjoy what I do. I don't see any reason to change that, as long as I have, the work I have, the bright fellows like you were and others are, they continue to inspire me. I think I get inspired by seeing how well the people I have trained, they are all over the world, and they are doing so well. They have become leaders themselves. So that gives me pleasure, and I think I enjoy that very much.
Okay, thank you. Thank you very much. It was a great talk, and it was great to see you again.
And to you,
congratulations again, and thank you.
Okay, Kasia. Ciao, ciao.